Thank you very much, and thank you to the department for the opportunity not only to be here, but for some of the funding for this study. Um, just want to kind of run through what we've been able to do in a shortish period of time looking into this really important question. I'd say the first thing as a True Seed grant we did is try to turn this into next steps. So we've been pretty successful at being able to find some funding for this, including I'll talk about at the end, a portion of this we're going to continue to work on with a grant from the Stanford Cancer Institute. So been really excited about continuing some of this work. So I just wanted to start with a basic case presentation. So imagine you're treating a 67-year-old woman who initially came to her primary care physician. She had 6 weeks of bloody stools, some change in her bowel pattern. She'd been eating less than normal. She gets a colonoscopy, and this is what the colonoscopy finds. It's biopsied and comes back as an invasive adenocarcinoma of the colon. So I just want you to think about kind of how you'd expect this woman to be treated, what workup needs to be done, what kind of operations might need to be done, and then to ask, would you think that'd be different for the woman on the left or the woman on the right? Now, obviously, this is a rhetorical question. It really shouldn't be different. We're talking about the same case, the same patient, but to the extent that people who identify with different ethnicities, or racial backgrounds, receive different care in the United States, unfortunately, isn't a surprise to us anymore. We really know that disparities remain, especially for non-white Americans with cancer. So the graph, or the chart rather, on the left here is actually from an older study that Dr. Morris wrote, actually, looking at survival disparity between Black and white patients with different kinds of cancer. And so what I'll highlight here is actually the largest differences in survival are among cancers that are the most responsive to treatment. So if you think about what that probably means, it has something to do with how we treat these patients. So disparities in outcome are probably driven by access and quality of care. And that's what we're really interested in looking at. If you go to the literature, there's now a developing literature on Black-white disparities in cancer care. And among patients with colorectal cancer, we know that unfortunately non-Hispanic Black patients are significantly less likely to be diagnosed at an early stage, to undergo a definitive resection, for rectal cancer, to undergo a sphincter sparing operation, if appropriate, to be referred for adjuvant chemotherapy, and even after referral to receive adjuvant chemotherapy than white patients with colon cancer. A lot less is actually known about patients who identify as Hispanic or Latino. There's really not much in the literature at all, which is part of what drove our interest in this. We know that Hispanics in general have a lower incidence of colorectal cancer. However, they're also less likely to have an adequate lymph node resection, which is a marker of quality of surgery, and to receive chemotherapy, both in the adjuvant and in the destination setting. But really, there's not much else out there in the literature. And so when we think about historically disadvantaged populations, it's possible that some of the mechanisms driving these disparities are the same: differences in socioeconomic status, lack of insurance, underinsurance, poor social support. But it's also possible that there are other mechanisms that are specific to this particular population that we haven't really uncovered, and therefore we don't have any policy solutions for it. So this may be language proficiency, acculturation, health beliefs, things like this. So our major goal in the work was really to answer the first question: are there disparities in access and quality of care for Hispanic Californians with colon cancer? And then most importantly to me as a health policy researcher, can we try to identify some potential mechanisms underlying these disparities and then design data-driven policy interventions that can improve health equity? So these are kind of our driving questions in most of our work. To do this like a good health policy researcher, we used a linked data set. So a plug for linked data sets, if not something you guys are already using, really, really powerful in trying to describe how patients go through our healthcare setting. So we were able to use the California Cancer Registry, which is the largest statewide population-based cancer registry in the US. It has longitudinal data on cancer diagnosis, treatment, and outcome. And then we were able to link it to the HCAI databases, used to be called OSHPA. You may have heard that or be familiar with that. It's really 3 separate administrative databases for the state of California. The one that's used the most, the one that we used, is the patient discharge database, which has information from all inpatient discharges from California licensed hospitals. So with these 2 databases linked together, we can see how patients are diagnosed, how they're treated, what their hospitalizations look like, and things like that. So we were able to start by finding all patients who were diagnosed with colon cancer in the state of California over an 8-year period. We excluded some patients just to have a homogeneous population so that we could kind of compare what was happening. So as you may know, one stage 4 patient is not exactly like another stage 4 patient. Sometimes it's hard to get that from the data themselves. So we started with patients with stage 1, 2, and 3 disease. These are patients that in general should be having an operation for their colon cancer and potentially a curable one. And then we were particularly interested in what role hospitals play in helping to kind of drive what we call pathways of care or access and quality metrics. So we looked at the hospitals these patients were going to and described them by how many colectomies they were doing, as well as what their risk-adjusted 30-day mortality was. You can see we created a bunch of quality and access metrics that are listed here on the right of the screen. And then we used multivariable regression to compare risk-adjusted survival, as well as these measures of access and quality of care after adjusting for a variety of socio-demographic factors that we had in the literature. So we were able to capture about 63,000 patients in the state of California for an 8-year period. About 21% identified as Hispanic or Latino. In general, the Hispanic and Latino patients were slightly younger. They're less likely to be living in a rural area, but more likely to be living in poverty in an area with a low income based on their census tract. When you start to compare them, we found that Hispanics, even among those in stage 1, 2, and 3 disease, were more likely to be diagnosed at a later stage, maybe because they had poorer access to care. They're also less likely to be treated at a high volume hospital, a hospital that's doing a lot of colectomies. However, they were less likely to die. And you can see actually the Kaplan-Meier curve with the blue line being Hispanic and Latino patients and the red line being non-Latino white patients. This is kind of the crux of our analyses here. These are 5 separate quality metrics. The final 2 are actually the only 2 National Quality Forum endorsed measures for colon cancer. Those are measures of quality of care. And then we compared these after adjusting for a variety of factors between the Hispanic and Latino population. So I'll just walk you through one of these charts here. So for, again, these are patients with 1, 2, and 3 disease. We'd expect that nearly 100% of them would be having a definitive operation. And that's about correct, about 97% of each group. You don't see much of a difference here, but with a large population, you're able to find some differences. There's about a half a percentage point difference between Hispanic and non-Latino white patients in their likelihood of having a definitive surgical resection for their colon cancer. However, when you start to look at having this operation in a timely fashion, and we define this as between 7 and 30 days out from their diagnosis, you can see that Hispanics are about 4 percentage points less likely to have this operation done in a timely fashion. Not as much of a difference in receipt of adjuvant chemotherapy. However, again, as has been shown in prior studies, when we look at the quality of the operation, how well the lymphadenectomy is performed, there is a significant difference, about a 3 percentage point difference between Hispanic and non-Hispanic white patients. So we wanted to explore this a little more because, again, we're trying to unpack differences, explain mechanisms in a way that allows us to generate policy interventions. So this is an exploratory method called a variance decomposition. I won't go too much into detail other than to just kind of walk you through how the basics of it work. What this allows us to do is take a look at a specific disparity and try to break it up based on whether that disparity is occurring within the same hospital or has to do with the kinds of hospitals that patients go to. So for example, in this top line here, again, we're back to whether patients underwent a definitive operation in a timely fashion. We can see in the middle, there's about a 2 percentage point difference. It's slightly different from the other literature because you have to exclude some hospitals when you're using this technique, but about a 2 percentage point difference between Hispanic and non-Hispanic whites. And then as you break it apart, you can see that actually most of that is driven by Hispanics and non-Hispanics being treated differently within the same hospital. So about 1 1/3 percentage point of that 2 is from a within hospital effect. It differs, for example, on adequate lymph node resection. So for adequate lymph node resection, there's about a 1/3 of a point difference between the groups. That's driven almost entirely by a between hospital difference, which suggests that it's Hispanics and non-Hispanics going to different hospitals, Hispanics going to hospitals that are less likely on average to do a high quality operation. So this is very exploratory. It's something that we're actually presenting at Academy Health in a couple of weeks, but it's a way to try to understand these disparities and therefore create policy interventions to close them. This is another way that we wanted to kind of look at and describe this. Some of you may have seen this. We presented this at Pacific Coast this year. This is what's called the Sankey diagram, and it shows the flow of patients through a course of care. So for Hispanic and Latino patients, we can see that about 70% are treated at a high volume hospital. Among those, about 31% have a timely operation, and 81% of those have an adequate lymphadenectomy during their operation. So this would be kind of the ideal care pathway for at least these metrics. When you compare that to non-Hispanic white patients, you can see that non-Hispanic white patients are more likely to be treated at a high volume hospital. And even among those being treated at a high volume hospital are more likely to have a timely operation and more likely to have an adequate lymph node resection. This occurs in other pathways as well. So for example, among patients who went to low volume hospitals, about 24% of Hispanics who went to low volume hospitals had a timely operation compared to 32% of non-Hispanic whites. Interestingly, if you use these in order to create these distinct pathways of care, you really don't find much of a survival difference, which again goes back to the point that it's really how we treat patients that's driving most of these disparities. So among, again, this top line being the ideal care pathway, high volume hospital, timely operation, adequate lymphadenectomy, there's no difference at all in the predicted 3-year survival. And you can see that tends to carry stepwise down as you start to not meet as many of what we would call the ideal pathway, with the biggest jump actually being between high volume and low volume hospitals. So hospitals are really driving a lot of the disparity in care. So our major takeaways from this initial research was that Hispanic and Latino Californians unfortunately have lower access and quality of care based on the metrics that we looked at. They're diagnosed at an advanced stage, they're less likely to use high volume hospitals, more likely to experience delays in non-receipt of recommended care than non-Hispanic white patients. And the treatment facility really matters and defines the care pathways. High volume hospitals are significantly more likely to meet timely surgery and NQF endorsed metrics for all patients, but even more so for Hispanic and Latino patients. I didn't get into it here because I already packed too much into this talk, but we see that there's an even larger marginal difference when we interact the two and start to look at how Hispanic patients going to low volume hospitals seem to do even the worst. And then when we start to try to explain this, there are different mechanisms underlying different disparities in care, meaning that our policy solutions really need to be aimed at trying to figure out why a disparity is occurring and what can be done to close it. Nevertheless, we found that Hispanic and Latino patients have a higher risk-adjusted survival, which is a little bit perplexing until you start to go and think about it. Really, the question becomes, are we measuring the right outcomes? Is this the thing that we should be using to try to determine if there's a disparity in care? I was actually personally shocked how many people came up to me in different various stages of this and said, oh, great, there's no disparity. There's no difference in survival. Right? And I responded, so you're saying that we give Hispanics on average bad care and they don't die from it, and we're supposed to celebrate that? So obviously, it just means we're probably not measuring the right outcome. And so we need to really know what else is going on. There's some other part to the story here that we're missing. So part of it is if you go and you really look in the epidemiologic literature, there is this epidemiologic phenomenon called the Hispanic mortality paradox, which in partly means we just don't understand what's going on. But it appears that Hispanics on average have slightly or better even health outcomes, despite generally higher levels of sociodemographic disadvantage. There are some potential explanations for this. It may be that Hispanics are healthier in unmeasured ways, kind of a selection bias that we're not really able to measure well. Part of it is probably that mortality data is incomplete in some systematic ways. For example, ethnicity isn't always reported on death certificates. Some Hispanic patients may use non-reporting facilities. Some also, especially those that have immigrated to the United States, may emigrate prior to death, and therefore we don't really capture them. It's also possible that the population is more resilient to medical and non-medical factors than non-Hispanic whites. Whatever it is, we're finding that this paradox is closing over time, meaning that Hispanics and non-Hispanics are dying at near the same rates. And this could be from demographic changes, it could be from acculturation. I tend to think maybe it's because the disparities in care are finally catching up. We've seen those for long periods of time, and now that mortality difference is starting to close. But probably most importantly, mortality is just an insufficient measure of health equity and health quality. So we need to think a little bit more deeply, and we need to look at other measures of health equity in order to try to describe this better. And sometimes when the data run out, the best way to do it is to create your own data and to go and really try to understand this at a different level. So that's what we're doing now. We're moving on to the next phase of our project, which is a qualitative project to look at the experiences of care among Hispanic and Latino patients with rectal cancer. We are naming this the Acuerdo study, which means understanding, trying forced a bunch of words into here to make that make sense, obviously. But we're really interested in Hispanic and Latino rectal cancer patients as well as their caregivers. This is a community-based study, so we're partnering with community groups. We're working with a community advisory board, and we're trying to understand what treatment experience is like, what barriers and facilitators to the receipt of recommended care might be, and most importantly, if there are any actionable targets for improvement. We're doing this in the Bay Area as well as in the San Joaquin Valley because we don't think that those areas are necessarily the same in how people access care. This was a project that came out of some of the data that we generated from the department seed grant, and we're able to apply for and receive some funding from the Stanford Cancer Institute. So really excited to continue this work into the fall and beyond. So I know that was a lot I packed into a short period of time, but I just wanted to thank the department for the seed grant. It was really helpful in generating some of these data, and then from the Stanford Cancer Institute for continuing to fund some of this work. I really wanted to take a second and thank the team up at Aspire. A lot of help. This was not a project that came about by any one person. Thank them very, very much, our analytical team and our advisors. And then the Acuerdo team it's a partnered study actually with it's a partnered study actually with the Department of Radiation Oncology. Dr. Zaki is a radiation oncologist, and then our community advisory board members who are taking their own time to support us in this project. So with that, I'd say thank you and take any questions.
We could take or